Welcome, everyone. I am Dana Alban. I'm a physician at the University of Virginia, an associate professor.
And good afternoon. My name is Golnar Raisi. I'm an integrative physician and a member of pediatric CF at Columbia University.
Welcome, everyone. I would like to start by introducing our first speaker. Our first speaker is Dr. Rerai. Am I pronouncing that correctly? She's an assistant professor of genetic medicine and certified genetic counselor at Johns Hopkins University. Welcome.
Thank you. Get this going here. So thank you so much for the introduction, for the invitation to speak today. That's just shaping up to be a really great session, and I'm excited to talk to you about genetic diversity as it relates to CFTR around the world. So we're going to see if I can figure out the tech here. Okay, I have no relationships for this presentation. Can everybody hear me in the back? No, sure can't. Okay. I don't know how to solve that problem. Is that any better? No, people are not so-so. All right, I'll do my best to speak loudly. So here are the learning objectives for today's session. I'm going to focus on the first one, which is discussing CFTR variant distribution around the world, implications on CF diagnosis, and then modulator eligibility. So I'm going to start with what I think we have are accepted truths. So these are statements that I think we throw around and everybody just kind of nods and goes along with it. So the first is that F508del is the most common CF-causing variant worldwide, that F508del has an approximate variant allele frequency of 65 to 70%, and that the ability to treat individuals who have either one or two copies of this variant means that about 85 to 90% of the CF population is modulator eligible. So I think we've all kind of heard this, but the actual truths are a little bit different. So indeed, delta F508 or F508del is the most common CF-causing variant worldwide. And it does have an allele frequency of somewhere in the 65 to 70% range in some populations. And we can treat 85 to 90% of people with CF in some populations, but not all. Much of our understanding, is this a little better for the people in the back? Okay, super. Thank you, IT help. Much of our understanding of CFTR genotypes is from individuals with CF who come from European-derived populations. So these are people we often describe as white. Many people with CF are Ashkenazi Jewish. But of course, we know that cystic fibrosis affects people from all ancestral groups and populations globally. So I'm going to start by showing you some CFTR2 data. Most people in the room are at least probably somewhat familiar with CFTR2, but here's your one slide primer for those who are not. CFTR2 is a global initiative to collect genotype and clinical information from individuals with CF who are enrolled in CF registries or seen in CF clinics around the world. Our current data collection, which is new as of yesterday, is almost 123,000 individuals, and these people come from 55 countries, regions, territories from around the world. They've got about 2,100 unique variants reported in this data collection. And available online now are over 1,100 variants with a CFTR2 interpretation. So where I wanted to start was what we can learn from this collection. And so this is a global map of the countries that have patients represented in CFTR2, and they're colored by F508del allele frequency. And so you can see these darker colored countries have a fairly high 508 frequency of over 70%. We've got a group in the middle here, allele frequency somewhere in the 50 to 70% range. And I'll pause for a minute to call out the European CF Society contribution. This contains data from 24 different countries. Yes, the delta F frequency varies in those countries, but we get it as one big group, so I can't separate them out. And then lastly, we have several countries colored in light colors where delta F508 is either very low frequency or not reported in some of those populations in the data set that we have in CFTR2. And so when we put this all together on a map, what we see is a really broad range of delta F allele frequency, which should clue us into the fact that countries that have a low delta F allele frequency must have something else going on genetically for the people in that country that have CF. And indeed, We know about this for some countries, so I've pulled just a couple examples from the literature. We know about H609R. This is a relatively frequent variant in people from Ecuador who have CF. We know about M1101K in the South Dakota Hutterite population. Probably most people in the room have heard of or are somewhat familiar with W1282X, which is quite common in Israel and people who are Ashkenazi Jewish. And then G97DD, which is thought to be one of the most common or more common CF-causing variants in the Chinese CF population. Now, this concept of genetic diversity in CF is not at all new. This paper that I'm showing here is over 20 years old. This is a really comprehensive view of worldwide analysis of CFTR genetic diversity. So like I said, this was published over 20 years ago. The data from this paper is probably 10 years older than that. But this group of authors did a really comprehensive look of many, many places around the world, not just Europe, that's sort of what's being shown here, but they looked at specific variant frequencies, different panels used in different countries, and this is just a small excerpt of a very large table that has over 80 regions included. And if you can read the small font, which you don't actually have to, but basically what we're showing here is that the allele frequencies of these CF variants are different in different places. Now, what I also wanted to show you, that data was from about 20 years ago. I did a quick search for allele frequencies, variant distributions, just from the last few years, and we're getting a lot of publications and data about this. So we've got a publication from Cyprus, from Kazakhstan, from Mexico, from the Kingdom of Bahrain, from South Asia, from Iceland, from Brazil, from South India, and there's actually 2 posters here at the meeting as well that have data from specific populations. So we are starting to gain an appreciation, or gain a better appreciation, of the genetic diversity of CFTR variants across the world. So the real question is, who cares? So what? Well, lots of reasons for this. I'm going to focus on 3 main ones today. So the first is that variation in CFTR genotypes may confer differing CF phenotypes. And this can confound or lead to the under-recognition or under-diagnosis of CF in some regions. I'm going to give you a couple examples. So CF phenotypes differ by variant. I think most people have a good understanding that when you have CF variants that confer residual function, residual CFTR function, we often see a milder or more ameliorated version of disease. Might be later onset, maybe milder lung disease, things like that. Now, what I'm going to show you here is a recently published paper out of India. There was one center that looked at their patient population, about 120 people, and they were able to subdivide their patients into people who were from this Bengal region in the northeast of India, compared to those from the South Indian population. And it's not so important that you can actually read the small letters there. I'm going to give you some information on that in a minute. But what I want you to notice is the difference between the colored bars in the Bengal region versus South India. Those are allele frequencies for the same list of variants. And hopefully what you can appreciate is that they are not the same. And if we want to talk specifics here, which I do, we can circle 2 variants that occur in the Bengal population at a relatively high frequency. So about 1/3 of alleles from this particular patient population contain one of 2 variants. The first is 3849 plus 10 kb C to T. The other is a missense variant called V456A. Some of you probably can recognize one or more of these. The important take-home note about them is that they both have significant residual CFTR function. And so the people with these variants are often milder or have later onset disease. And so I've pulled some data out of CFTR2 to show you what this looks like, at least from objective measures here. So when we look at individuals with 2 copies of delta F508, we see a mean sweat chloride of around 100. Almost everybody is pancreatic insufficient. Conversely, if we look at people who have 1 copy of delta F508 or similar variant, and then 1 copy of either the 3849 variant or V456A, you can notice an appreciably lower sweat chloride in that group and significantly lower percentage of people who are pancreatic insufficient. So what this means is that these patients may not present in that sort of classic infantile CF with malnutrition or failure to thrive. They may show up with pancreatic sufficiency or pancreatitis. They may show up with sort of non-specific respiratory problems that don't occur until later. And so that can sometimes confound a diagnosis. It may not look like the sort of textbook classic CF that we've learned about. The paper did not break down variant-specific phenotypic differences, but they did show that overall the Bengal population had about 60% or just under 60% of people with a diagnostic sweat chloride and only 50% pancreatic insufficient, presumably driven by these variants with residual function. And that the group from South India had more patients with a diagnostic sweat chloride and a significantly higher proportion who were pancreatic insufficient. This is a paper that did somewhat of a similar analysis from 2018. So this was a group of 71 Chinese patients with CF, and they compared frequency of certain symptoms to the US CF population from the 2017 data report. When we look at something like bronchiectasis, both groups had a relatively high frequency, about 90% or more. But when we look at other symptoms like upper airway involvement or pancreatic insufficiency, the Chinese patient group had significantly lower frequency of these symptoms than the US population. So same take-home point as the last slide, these populations in other areas, which are driven by other CFTR variants, may look a little bit different. Now, in some countries, there's also a confounding factor of other conditions. So particularly in some low and middle income countries, some conditions are going to present similarly to CF. So malnutrition, tuberculosis, HIV, other infectious disease may confound the diagnosis. And we also may just have a lack of awareness of healthcare providers about CF in general, or that CF can affect populations that are not white or European derived. And that is not unique to specific countries. That is pervasive everywhere, including in the United States. All right, so point 2 that I want to make. It's important to understand global genetic diversity because the utility of commercial variant panels may vary across the world. So we know that the utility of these panels is not uniform. They have limited utility in some or maybe even many populations. And having an understanding of the genetic variant spectrum that you're looking for can really aid in more accurate test selection for carrier screening, for diagnostic testing, and for newborn screening. The next 2 slides I'm going to spend on newborn screening, so I'll just remind everybody that in most countries around the world who do newborn screening for cystic fibrosis, starts with an IRT measurement. If that IRT measurement is elevated, the sample will get reflexed to a DNA panel of some size. That DNA panel may range from 23 variants up to 100 plus. Now, what we know, I'm going to show you first data from the US, is that a person's ancestry, or where they're from globally around the world at some point back far enough, that ancestry impacts the utility of the panel you may use. Now, this data is courtesy of Megan McGarry, and this was a study that looked specifically at CFTR variant detection, 1 or more, in babies with CF in the California newborn screen population, using a 139 variant panel, which at least for some amount of time was the largest commercially available CFTR panel. Overall, this has pretty good detection, actually. We can get over 95% of babies that have at least one variant detected on this panel. But when you break it down by population or ancestry, the detection is lower in babies who are Asian, so only 72% pickup, lower in babies who are Black or African, 83% pickup, and then pretty darn good in babies who are white or European-derived populations of almost 97%. So we know that this varies even within just one state, ancestral backgrounds within the US. Now I'm going to tell you a little bit about Poland's newborn screening strategy, because this is very interesting and not one that I've seen used elsewhere. So when Poland started newborn screening, and this was back in the early 2000s, they had a problem. The commercial DNA assays that they wanted to use in their newborn screening strategy did not include all of the relevant variants for the Polish population. And they specifically called out the variants K710X and 2184 insertion A as having a frequency of about 0.5% in their population, but these variants were not on the panels that were available at this time. This was also not a time when we were doing sequencing as part of newborn screening. That is something that is used in some places and becoming more widespread. That was not a thing in 2006, 2007. And so Poland decided they actually would add a sequencing component only for specific exons of CFTR that they knew harbored variants that were seen in their population. This was a fairly novel approach. They still use a version of it today. They've added a few more exons over the years. I've really not seen this repeated elsewhere, but they had success with it because it allowed them to pick up more patients in their population that had Polish-specific variants. Exon deletions can also help inform testing strategy. So exon deletions are considered structural variants, and one that you may have heard of is called CFTR del23. This is when you are missing a chunk of DNA that corresponds to the coding region or the exons 2 and 3 in the CFTR gene. Now, this is a variant that is relatively common in Central and Eastern Europe, where delta F508 is a little less common. There's also a similar variant where you're just missing exon 2 that's more common in Sardinia and Turkey. Now, this is all well and good. We say, oh, great, we've determined variants that are frequent in these regions. Now we know about them. Here's the problem. Structural variants require a different type of test. You often cannot detect them on commercial panels. You often cannot even detect them by a sort of typical sequencing test unless you add on deletion duplication testing or deletion duplication analysis off the sequencing testing. So there's a separate step that's needed here. And so understanding this variant spectrum in a particular region can help inform you what kind of diagnostic testing or carrier screening or newborn screening you might need to use. Lastly, this is the point I think most of us are very interested in. We know that modulator eligibility is not uniform across the world. And I'm going to get one thing out of the way right here. We are not, jumping the gun. We are not treating 90%, 85, 90% of individuals with CF with modulator therapy. We're just not. This is data that was put together by Jonathan Guo, who has presented many times over the last few years at this meeting. And in this more recent publication, he's been trying to define, using some modeling to define how many people in the world actually have CF and how many of them do we know about. And with that, how many of those people are we actually treating? And the estimates right now are that we're treating about a quarter, 27% of the worldwide population. Now, if you adjust that for the people that we think are diagnosed with CF, it's close to about half. But we know it's not 90%. Now, the reasons, of course, for this are mostly twofold. Either people don't have modulator-approved CFTR variants, or they don't have access to modulator therapy related to government regulations, financial constraints, et cetera. That second point is an entire talk or session all into itself and is not something I'm going to address today, but I will talk about the first point. Some people don't have modulator-approved CFTR variants. Now, why is that? Well, either they have variants that don't respond to modulators because they're not of the type that we can treat with modulators alone. Those are people who are going to need some other type of therapy, maybe in addition to modulators, so gene editing, gene replacement, things like that. But the second category is people who have rare variants that might respond to modulators, and we just haven't tested them. We also know that that type of variability, that eligibility for modulators varies by region. So in Turkey specifically, just under a third of 445 patients from a single center were reported to be ineligible for modulators based on genotype. Now, about 2/3 of that group did harbor at least one class 1 variant. Those are the types that are not going to respond to modulators alone. We need additional therapy. But that means that the other third of that third probably just has a rare variant that needs to be tested. If we look at the UK registry, this was a publication that looked at modulator eligibility from the 2022 data collection. Nearly half of South Asian patients were not eligible for modulators. And in the Cyprus registry, the numbers are getting a little closer to kind of what we hear. They had about a quarter of patients that were not eligible based on genotype. Now, not to be all doom and gloom and just say, well, people are not eligible. We can actually do something about this. Of course, we know that there are therapeutic developments in line for people who have non-modulator treatable variants, so things like gene replacement, et cetera. But we also know that we can study rare variants. So we know that we have in vitro data available to us. And this is a recent publication out of, mostly done by the CFF Therapeutic Lab, where they actually tested over 600 variants for their response to modulators. And if you're interested in hearing more about that paper, there's a symposium tomorrow afternoon where that will be presented. But we can gain this type of information. So my final note, and then I'll close out, is that as much as I just said, hey, we know a lot about this diversity, it's not a new concept, we have all these publications, we also know that our understanding of this diversity is still underdefined. So this was a paper that was released in 2023, and it looked at a genetic spectrum of Chinese children with CF. As a supplement to this paper, they included the list of 160 variants that were identified in this population. And when I looked at that list of 160 last year, CFTR2, which has 2,100 variants reported to us, had only heard of half of the variants reported in this paper. So there's a good chunk of populations around the world that we still don't actually have a great handle on the genetic diversity. And there are many, many manuscripts that are coming out where they're still reporting variants that have never been reported before. Now, these are not necessarily novel, they're just existing in populations where we haven't seen those reports yet, but they're coming. So this is my last example. The mutation analysis program is helping to increase knowledge on genetic diversity. Now, MAP is a CFF-funded program to genotype people with CF who have fewer than 2 disease-causing variants identified. At this time, it is only open to US patients, but I'm going to demonstrate why I think we can still gain knowledge about global diversity. So here's my example. There's a patient referred to MAP. This patient had one known variant. MAP found another one. This is an interesting deep intronic variant that had not been reported before. As follow-up to MAP, Dr. Neeraj Sharma in our lab has a functional testing grant, so he was actually able to test this variant in the lab and determine that indeed it does cause missplicing and is very likely the second causal variant for this patient. Great news. By the way, he was also able to test different therapies on it, and it turns out it is modulator responsive. And so we were very happy to feed that information back to this patient. And I'm sure the family was very happy to receive this information. But with this, we learned a couple of things. One, now we've got clinical data from a person who has this variant, so we can learn a little bit about what it looks like phenotypically. Two, we can learn about the type of testing needed to pick it up. This is a deep intronic variant. You have to do in-depth sequencing to find it. And three, the piece I didn't tell you is that this patient, who is from the US, is of Indian descent. And this potentially represents a variant that is common, or at least not totally rare, in the Indian population. We're hoping to get more information about that because, as luck would have it, MAP just identified a second person with this variant. And now we're going to be able to tell that person what we learned from the first. And eventually, this will hopefully get out into the literature. There is a poster on it if you'd like to go learn more about this very specific variant. So I'm going to wrap up here and say, we'll bring us back to where we started. We can learn a lot, actually, just by looking at the frequency of delta F508 around the world, because it gives us an indication of where we should be looking for other things beyond delta F508. Well-accepted statistics about CFTR variants do not apply to all populations. That's number one take-home point. I think people probably know that, but I'll say it. There's a lot of genetic variation in CFTR. We are getting new variants reported every day still. And that if we continue to increase our understanding of this genetic variation, we hopefully can help providers recognize CF better, allow for more accurate and useful test selection, and of course, overall, inform plans for potentially expanded CFTR modulator testing and access. So thank you very much for your attention, and I'll take questions for 1 minute.
Thank you so much. That was an excellent presentation. We are going to have 5 minutes for questions. And you have the option of asking questions online or at the 2 microphones.
Yeah, so officially, the only people who can suggest and get approval for changes to on-label access to modulators are the pharmaceutical company that makes the drug to submit to the FDA or other, EMA, other organizations, Health Canada, to approve those. So CFTR2, unfortunately, has very little role to play in actually getting those approvals through. But we are very happy to continue to identify at least a large variant spectrum and feed that back to people who can do drug testing on these variants. So that paper that I showed earlier, that 655 variant paper, that list of variants to test came from CFTR2 because we said, hey, this is a whole list of rare variants that need to have their modulator response tested. Now, again, the people who did that cannot submit to the FDA for approval, but that's the type of data that could be used. Yeah, thanks so much for your comment. And if you want to chat with me afterwards, we are still looking for CFTR2 contributors. So if your country is not represented, we would be thrilled to have a conversation.
We'll take one more question.
Hi, I'm from Malaysia, so very far and it's not reported, but we have cystic fibrosis patients, and I check my patients' data. More than 50% is not in CFTR2. So, and we published the paper, but unfortunately, maybe we are so lower middle income country, so our paper very difficult or challenging to be published and be noticed nationwide. So I will be thinking once, how would I contribute my genes data to you guys so that eventually it will benefit us in a way of care. That's why I flew all the way here.
Yeah. Yeah. I'll just thank you so much. I'll reiterate, we would be happy to have a conversation. We know that CFTR2 still does not have data from a lot of countries. Not every country needs to have a registry. Registries are easy. They're easy to get data from for us, but we are happy to work with individual clinics. So I'd be very happy to have a conversation because when you put the data in, I bet there's other people in the data set that have those same variants. And then we can get enough people to actually like look at them and present online. So yeah, thank you so much.
Thank you. That was a great point. And that's exactly the point that we wanted to make with this presentation is that genetic variants exist around the world that we may not know of, and what we have in the United States may not be similar to other countries. So thank you all. I would like to introduce our next speaker, and our next speaker is Dr. Gutierrez. He's a Raymond Lyrine Chair and Professor and Director of CF and the Division of Pulmonary and Sleep Medicine, Department of Pediatrics at UAB.
Well, thank you for having the time to be here and listen to what we are to say. And thank you so much for the organizers and the chairs to invited me to present this. We're going to completely change gears from Karen to a far more pedestrian type of conversation. But the intention is the same. How can we improve what we do in CF from a area that we are privileged to be? I'm in a very large, sophisticated CF center. And how can I do that to areas that are less benefited with the resources that we have? And that actually counts to far more than half of the patients with CF in the world. If you just give an idea, there are 30,000 patients with CF in the US. There are 650 million people in Latin America from Mexico to Antarctica. And that is far more patients with a lower incidence than all the US and North America. And those patients are not being treated or found in the same way that we are found here. So I have been grateful to be funded by the CF Foundation. It's the only disclosure that I have. And I had the opportunity to contribute in a paper that was led by Scott Bell and Felix Rutgens a few years ago, and actually Karen was participating in my section as well. And so what were the challenges in CF care in the developing world? So first, the organization of CF care is not what we are used to, the CF Center network in Canada, in the US or in Europe. They're clearly beyond what we can discuss today here or at my level, the geographic, economic, and political barriers. The training. We have been supported by the CF Foundation for many years, for decades, to the CF team, the care teams, to develop an approach that has been very standard and highly efficient and effective. That's not the case in other countries. And there are a wide range of training and expertise that is deployed to the patient care. Access, we already know that is not up to par. Also, the concept and the delivery of care at the microsystem level is different. The structure of care delivery, the structure of how the doctor is considered in the medical team is different in many areas of the world. It's more pyramidal than horizontal in the terms of exchanging and leading the care of the patients. Everything depends on the doctor. The doctors need to say this to happen. If not, it doesn't happen. And that the structure of the system actually ask that to the doctors, to the team to do that, which is difficult. And then the role of patients. We are fortunate to have the CF Foundation that was started by parents, but is not the same case in many countries. So what can we do at the center, team level? This is what I'm going to do only to the level, what I'm able to do as a team member of a CF team in the US, when we started. Forget about those. Organization of care is very difficult to change from a team member perspective, but we have gained an expertise, again, by quality improvement that started more than 20 years ago in the CF Foundation, and the team learned to do that better. So we are executing much better even before the modulators. And you can see, remember how the life expectancy in the US was increasing despite no new medications. Then that changed when the modulators came. And also the clinical care team as a clinical microsystem is essential. So understanding that we have gained, the medical, the CF team, from the social worker to a doctor, that's the team. We come with the idea that we can train others, not appear from, Atlanta at Emory, because they have the same kind of skill. But there are teams who have great potential, but they don't have the skills. I always use the analogy of soccer. Let's bring Argentinians to teach Americans how to play soccer, okay? Or Canadians. So here's the same. You have the expertise, but you need to transfer that expertise to potential good teams. That's what we decided to do. So having a US-based high-performing team that we call coach, a trainer, okay? And Nick Saban, anybody? And we find a team from a low and middle income country that has high potential. What is the high potential? Interest. They want to improve, not resources. I went to my alma mater in Chile, and a very sophisticated medical school, fortunate to be, but they said, no, thank you. So the potential is actually finding somebody who has the interest, who understands what you want to do, and see if that works. So we started to train some people, and we came up with, as we decided this in 2014, as we go, how this work. So we were learning along the way. We didn't have, this is what we're gonna do. PDSA was actually every day. Okay, we tried this, it didn't work. Let's try the next one, then the next one, then the next one. So over several years, we developed what we call the bi-directional benchmarking. So the trainer goes to visit the trainee team and vice versa. So the trainer, they visit the trainee center, and those are the key drivers that we were taking into it. A direct observation, how they operate. We need to know first how they are playing to understand, hey, you need to correct this, you need to improve the defense, the goalkeeper is good. You need to see them performing. And then we have informal meetings, helping them to managing up and managing out, reaching out to the director of this hospital to do better. Sometimes they didn't even know how to do it. The 5-minute elevator talk. I'm very used to, because my clinic, my office, is in the same floor of the C offices of my hospital. So I train to do 5 minutes talk with people who really can influence my resources. So all that was happening when we were visiting the trainee team, the team that we are coaching. And they were coming back to visit the trainee center. And then they observe how we perform, but not at the level of showing off, at the level of how we go the detailed things. And it wasn't a specific intent to limit the role of the leader, which is the center director, and excel and try to improve how the rest of the team works. So we're seeing that all leaders, from the social worker to the nurse, etc. And then we started to do an ongoing support. So this is 1 week visit, one team comes, the other goes, and so in a year or so. Other thing that we were putting together is how the trainee team improve. 2 key things: the functioning of the team, a great emphasis on how they can play. I always say to my colleagues from Argentina, if they have 11 Messis, they will not be winning World Cups. They need to distribute the abilities, and they need to work as a team. The analogy actually of soccer or football, actually is very pertinent to this thing. And then the quality improvement. So the trainer team was trying to model the healthiest teamwork to encourage them to develop their own skills. And so the team function and become a high-functioning team. And the quality improvement, they have better processes and better outcomes. And then we follow their activities. Just conversation. I mean, this is Zoom, there's pandemic in the middle. And then essentially what we're trying to do is that team that we train, we transfer the know-how, it becomes a trainer for their local teams. So train the trainer. How has been the evolution of the trainer and the trainee? Here we both gained and we both grow. So in green is the trainer and in yellow is the trainee. We were going from ongoing support to just an advisory role. And then we're going with learning and doing to executing and growing. That in the course of one, sometimes month only, they were changing that quickly. And they were from improving the quality of care to actually standardizing the quality of care, from PDSA to SDSA, from learning how to work better as a team to actually leading. And you can ask the teams who have been trained that they are now role models, not for CF in other centers, but for other programs who are in pediatrics or in adult medicine, diabetes, asthma, etc. So this is what we call it the training network. So a coach, a US-based team, at the beginning was UAB and Baylor from Dr. Ruiz, took some trainees from Chile, Argentina, and Mexico. Those trainees now are becoming coaches, and now they're expanding their role to teach other teams in the way that we did it there locally. This was apparently welcomed by the CF Foundation, who asked us to compile this kind of training in a kind of a curriculum. And that curriculum, we call it the training initiative. And so the foundation called for a funding opportunity, and there were 15 or 16 or 18 teams that applied to the program. And we were fortunate to the CF Foundation selecting teams from Boston, Stanford, and Columbia. And in fact, Dr. Ulwer is presenting their experience as one of the second kind of wave of coaches training other teams. So here now we have how can I change, how can I help? By training other teams who have great potential. And this we have from Jordan, Mexico, Ecuador, from Dr. Sadegi's team, Baylor, Mexico, and UAB has taken Uruguay and Chile. How can we help? This is again wearing the hat of a CF team member. We are able to change what we can. It's what within my sphere of influence. I would love to have a way to say, I have Elon Musk money and I will get the medication for free. It's impossible, but I can do something. What I can do? Unleash the teamwork. That is what we have done. And if I can summarize in one thing is, we are empowering teams who have great potential. Remember who was playing for, in the last World Cup? Morocco was a great team. Okay, made it to the semifinals. Never heard of Morocco before as a great soccer team. Football for the rest of the world, who knows? Empower and train them to work within their system, not to do what we do, is what to do according to what they can do there. Help them to manage app. Teach them how to actually rule. Well, we cannot teach politics right now, but we are a very bad model. And advocate to manage app. Get what they need. Teach them the basics. Okay? So they can improve within their microsystem and always show how a healthy teamwork should be working. We have our differences. We have some observing some crisis in the teams when they are realizing that they really have some issues that they need to solve, and that has been solved. And then make them to realize their potential. See, going from building a barn to helping in less than 2 seconds actually, to fix the car. Active collaboration. facilitate the network and be always available to them. It's just a phone call or an email that will help them. And know and help them to own the thing. And then cultivate leadership development. We are very fortunate in the way that our medical system nurture leadership at different levels. And this conference is a clear example of that. It's not medical MD driven. It's healthcare team driven. And that is actually one thing that is very important, in my view, for the teams in other countries, especially in low resources, that they need to change. It's kind of a paradigm to change that. And then provide basic tools. But then we want results. So what is the return on investment on this? Because you spend time. This is back almost 8 years ago. A small hospital had very bad. They were very happy because they didn't have Pseudomonas positive. The problem was they were not finding them. They were there. And it took just one clever medical technologist realized what they were doing wrong and they fixed it completely and became exactly the same incidence of prevalence of Pseudomonas that is reported worldwide, 50-something%. And it was just one small thing. That changed their appreciation to how to treat the patient. Although these are not significant statistically, but there's clearly a trend to improve. These are all data from patients on a public hospital in a very poor section in Santiago, Chile. I heard this morning that one team, adult team in Connecticut, New Haven, improved their time in about a bit more than 10% in patient coming to clinic and leaving the clinic 15 minutes earlier. So hospitals in Argentina, for instance, the patient need to go to the hospital pharmacy to get their medication. They need to have the paper. They need to travel back and forth. That's a waste of time. They were able to adjust the system and decrease the trips to the hospital just for the pharmacy, 77%. The total visit time, well, if New Haven is bragging about 15%, they go 24% in less than 6 months. And idle time is the patient waiting for the next provider in 50% reduction. And this happens after one visit to our center, and they work within a few months and they got the result. And you can see their abstract in poster 759. Another team from Mendoza, poster 830, they are improving this. These are patients without modulators. They had modulators, but they wanted to see what happened with the patients who are not on modulators. And the BMI by different age groups and the FEV1 was also improved. So we have been able to, only in Latin America, to be involved in, directly or indirectly, us indirectly, for almost 1,000 patients. And we have a WhatsApp list for more than 250 healthcare providers from Mexico all the way to Santiago and Chile. And we have monthly webinars, etc. And so we are using a registry that we developed with CF Foundation funding at UAB, and some of the centers are using that in a day-to-day management. It's a kind of a patient care management tool. So this is all what I have. I'm very fortunate to have the support of Dr. Faro, Namrata Patel, Baylor Fadel from Texas Children, who's taking care of Mexico, the IMTI teams of Columbia, Harvard, and Stanford, the Latin American Center, who have participated with our direct intervention, and my team and the UAB and Children's Hospital, who has given us all the support and time to travel. And thank you so much.
So we have 5 minutes for questions. If anybody has questions, 2 mics on either side of the room.
Hi, Dennis Hajaliadis here. Thank you for your presentation. Quick question to ask you is there something to tell us from the experience from learning about their situation in the other places? Because obviously, you know, what we have in a high resource setting might be not directly applicable to the low resource setting. So it's learning from us, from the team and all the resources we have, but is there something that we can learn from the different places and how to help them, use our model to adopt there. Do you have any?
So the question was, what can we learn from the other teams?
Oh,
From the other way, basically, something that you learn that maybe, because of their situation and how things are in different places. In Latin America, for example, where you seem to have more experience.
well, we have been, first, you need to, if you're going to coach in some area and you have no knowledge of, I have an implicit bias. I'm from Chile, so I went to Santiago because I know how the people drive there. So I'm very familiar with the situation. You need to have some degree of connection, language barrier. My team does not speak English, Spanish. It's only me who speaks Spanish, and all the others, right? We have done this for 10 years and they're still smiling. So the way that they give information is by us observing how they're doing and telling us also how the system works, that we need to adapt to what our system is here. Because there are many differences in the way that prescription dispensation, organization of care, you go from one province or state to another in the same country might be different. And so it's always a two-way road to learn, and we don't dismiss that.
Yeah. Do you have a pearl from your experience?
The what?
A pearl, some kind of knowledge, to share with us, something that
Yeah.
you learn or something that you saw.
Something that you observed.
Something.
Something that you observed between the two centers, for example, yours here, there.
Do you have something to share with everyone that you
From share, well, there's so many stories and laughing that it would be impossible to say one specific thing that comes to mind at this moment. But we have, and actually is a permanent learning and experience that we are gaining from them. We are surprised sometimes of how they organize. Actually, the surprise comes from themselves sometimes when they started to see that, well, we were doing it wrong and we never realized. And not because we're telling them the way, but because they are just playing or kind of reconstituting the step that they were doing, that before it was completely automatic, to say, okay, stop this and see how it works. And they realize that there are many steps that are not necessary to occur, or there's something else that needs to be done differently.
Hi, Samia Nasser from University of Michigan. That's great work. I really want to commend the CF Foundation for all the support they've been providing you, providing me. I also wanted to add that we are doing a lot of work in Egypt. I know you're aware. So I just wanted to put a plug for that. We're making huge changes by just going there and working with the team, and just little bit we're doing is making a huge difference. So, again, thank you to the foundation for all the work they've been helping and supporting. Otherwise, it would have been very hard for you and me to work on that. Thank you.
Yeah, I completely agree. Okay.
Thank you so much. This is wonderful work. And I would like to introduce the next person, Dr. Stevenson. She's a respirologist and an adult respirologist in Toronto, and an associate professor.
Okay. Thanks very much to the organizers for asking me to speak today. I'm going to be talking about harmonization of registry data, CF registry data. And I have no disclosures to mention for this presentation. So I'm going to start first with a bit of a history of the Cystic Fibrosis Registry. Some of you may know some of it, some of you might be news to you. And then I'm going to talk about some of the challenges and opportunities that we have when comparing data, and how we can use registry data across different countries to compare or to bring together to answer research questions. And then I'm going to end with a couple of examples of successful harmonization projects that I've been involved in. Of course, there are many others, but I'm just sort of speaking from my own experience about a few projects. So the CF registry really began back in the 1960s, and in 1957, a pediatrician in Cleveland felt that his patients had better survival than expected, and there were no registries at that time, so the national CF mortality was not really known. But eventually, the Cystic Fibrosis Foundation in 1964 gave $10,000 to Dr. Warren Warwick to collect statistics from 31 different centers across the country to see if what Dr. Matthews was saying was actually really true. And so he put together all the data, he analyzed the data and came up with a report, and lo and behold, there was a significant survival benefit at Dr. Matthews' clinic compared to the other clinics that he collected data from. And that was the first time really that the CF Foundation recognized how important it was to collect data. Whatever data you were collecting, at least you had some numbers you could go and say, look, this is what I'm seeing here. You're not just sort of waving your hand and saying, we're doing so much better here. You're actually showing some numbers. And Dr. Warwick was managing the registry, and in 1974, I actually meant to bring these just to show you because they're really fascinating to look at these reports, but in 1974 was the first report, one of the first reports from the CF Foundation summarizing the statistics from the registry. And actually, Dr. Warwick came to Canada and spoke to some of the Canadian CF clinics and said, would you like to join the registry? And a lot of the clinics said, yes, that sounds like a great idea. So they would send data from Canada down to the United States. And it was actually a joint registry from the very beginning. I don't know if people realize that. 1976 was the first joint report from the CF Foundation that summarized both Canadian and US data within the registry. So really harmonization goes all the way back to the 1970s. It's not something new. And this is these are tables from that 1976 report that show the Canadian summary statistics on one side, the American summary stats on the other side. There were just over 2,000 patients in Canada that had data collected and just over 20,000 in the US. And back in those days, you know, basic demographics were collected. There weren't a lot of detailed information, and of course, vital stats, so they could do survival calculations. And it wasn't until the early 1980s that there was a very amicable divorce. So these two registries separated out. The Canadian Cystic Fibrosis Foundation at the time took back the Canadian data and brought it back to Canada, and the US kept their data and continued on with the registry, and the rest is history. We have reports separately every year we put together. And so both the US and Canadian registries have been around for a long, long time, having data going back to the 1970s. But things have changed, and no longer are they using typewriters. And I'm looking at these reports thinking, oh my God, if someone made an error, they'd have to go and do this whole thing all over again from those early reports. Now we have digital computers. We put nice glossy pages and pictures on our reports. And lots of countries have started registries within their national registries, and they put out national reports. This is not a completely total number of countries that have registries, but just a smattering of some of the countries to show at this presentation. So we have these reports. So people might say, well, let's just compare the metrics within these reports, because we all collect data on lung function, nutritional markers, microbiology, all those sorts of things are pretty standard things. And can't we just look at those and compare and see how we're doing comparing one country to another? Well, it's not that simple, because sometimes the data are presented in a different way within the reports. And this is a graph from the Canadian report on your left and the US report on the right. And it's sort of hard to really see how does lung function compare in Canada compared to the States, just looking at this graph. One of the issues is that the lung function categories are different between the two registry reports. The age categories are different, so it's hard to say what's different between the two. And these are just some other graphs from other reports just showing you that the data are distributed and displayed in very, very different ways. So the European registry on the very left-hand side, the Australian registry, the scatter plot on the bottom right. So hard to compare. The other thing is the registry reports don't always specify what data is used to generate those reports. So I don't know if one country is using the best lung function of the year and another country is using all of the measurements and calculating the average lung function of the year. It's not really a fair comparison to say, oh, that person has better lung function, that country has better lung function than this country, because you're not comparing apples to apples. So it is a challenging situation. So that's sort of clinical metrics. Survival is a bit of a harder outcome. You're alive or dead, that's not sort of something that is open to interpretation. So surely we can compare the survival metrics between different countries. But it's actually not quite that simple either. And this is an example of two hypothetical countries in the columns. And it depends a little bit on the data collection, for example. If one country is very meticulous and captures all of the deaths, survival is probably pretty robust. But if another country is missing a lot of deaths, for example, after post-lung transplantation, they don't come back to the CF center, you're missing those deaths, it's really hard to compare. If one country has mild cases in their registry, like CFTR-related disease, and another one only captures people with severe CF, you can't really make those comparisons, and so on and so on. So you really have to be thinking about how a country collects the data and who's included in the registry before you can start really comparing. And we did a study a few years ago now just to quantify the impact that these things would have on survival. And the top left-hand violin plot is basically we took the Canadian registry data, we calculated what the median survival is, which is the first observed dot on the graph. And then the violin plot shows for increasing missing deaths, proportions of missing deaths ranging from 5% to 35%, you can see that the median survival age is going up. So it's falsely increased the more deaths that you're missing. Conversely, if you miss patients lost to follow-up, if those individuals lost to follow-up are not in your registry, you'll actually underestimate survival, which is the bottom left-hand violin plot, again showing the same thing of proportion of patients lost to follow-up from 5 to 35%. And depending on how you treat transplants, you also will affect survival. So this is a Kaplan-Meier curve showing the dark line, which is basically censoring at the time of transplant. So we're calculating survival, but once someone has a transplant, we don't look beyond that point. So we're ignoring all those transplants, deaths after transplant. And the light gray line is including patients with transplant. So again, in these reports, it's not always clear, are transplanted patients included, like the post-transplant deaths, or are they excluded? So I think it's difficult to compare the reports, and it's also unrealistic to expect registries to function and collect data in exactly the same way. It's just not realistic. It's not going to happen. And that's because, as I said at the beginning of this talk, some of these registries have been around for a very long time. They have a lot of resources behind them, a lot of infrastructure, and the purpose of data collection is different. So in Canada and the US, for example, we're sort of thinking now about, should we be collecting information on cardiac outcomes? Should we be collecting information on other emerging complications? But other countries, like were mentioned earlier in this session, countries that don't have a registry or are starting a registry, they just want to know how many patients have cystic fibrosis in my country, and what are they like? What are the lung function like? Those sorts of things. So the purpose of the data collection varies. But I want to show you that if you take time to understand the registry data, or any data that's captured, doesn't even have to be in a formal registry, any data that's captured within a country, if you understand how it's captured and how variables are defined, you can often do important studies that will harmonize those variables and bring them down to the lowest common denominator so that you can actually do research and answer important questions. And that's important because it will basically could identify gaps in care. You could use this information for advocacy purposes. The more data that you have across the world, you increase the generalizability of your findings, increase understanding of rare outcomes, as we mentioned earlier, these rare mutations, we don't know a lot about them. It's important from a global perspective to come together so that we can learn things about them. And we all will learn from each other the more we sort of talk about how we do things within these different registries. So I'm going to give a couple of examples of projects that I have been involved in that involved harmonization of registry data to answer research questions. And this was a project that I worked with my colleagues in the US. And this is a graph showing median age of survival in the United States from 1990 to 2013. And when you look at this graph at the beginning, you think we are doing well. Survival is increasing, everything is going well. And it's true, it is a positive message. But when you have the opportunity to come together, harmonize the data, and do the analysis together with another country, now you look at it and think, hey, wait a second. That's weird. Why is Canada's survival going up and ours is kind of staying flat? So, it's not as important to identify the disparity or the gap in survival, but then you ask the next question, which is, why is there a disparity in these two countries? And that brings us to the next part of what we did with this project was to think about what was causing the survival gap. So obviously universal healthcare came up because in Canada we have a different healthcare system than the US. Nutritional support was implemented earlier in Canada compared to the US. So if people had good nutrition from the time of birth, maybe they weren't dying as much later on in life. That could be a contributing factor. But another one was transplantation, which was a therapy that impacted survival fairly quickly after it was done. And these people were at high risk for death. So we thought we should look at the transplant differences in a little more detail. So we looked at differences on the waiting list in the two countries, and we found that there were more people dying waiting for transplant in the US. And then we looked at post-transplant survival between the two countries, and there was a difference there too. So we did a simulation study to basically make the proportion of transplanted patients and post-transplant survival to be the same between the two countries and redo the survival. And we found that the gap was reduced by 30%. So part of the answer of why there was that survival gap was related to transplant. And if you then go on to reduce waitlist deaths and improve post-transplant survival outcomes, you can impact and improve overall survival in the country. So I think this is just a good example of where coming together, this is just two countries coming together to answer important questions, can yield information that's very important and interesting. This is a poster 833. It's sort of a plug for this poster, and I don't expect people to read it, but the bottom line is that we've had a very fruitful Canada-US collaboration, and this is a most recent one where in the United States, of course, the approval of ETI happened in late 2019, and then the pandemic happened. We know that both the pandemic and ETI probably reduced pulmonary exacerbations. In Canada, we had a very delayed access to ETI, so it was like a year and a half later. So we had a natural experiment and an opportunity to look and see how much of the reduction in pulmonary exacerbations was due to the pandemic and public health measures, and how much was due to ETI. And we were able to tease it out so that there was a reduction from public health measures, hand hygiene, masking, all that sort of stuff, but there was over and above an increase in reduction from ETI over and above the pandemic health measures. And I encourage people to visit the poster to get more details on that if you're interested. Now, going beyond two countries, I want to spend a minute talking about the global aspects, since, especially relative to this symposium. But since 2013, there's been an interest in multiple registries across the world getting together and talking about how we can harmonize things and what other research we can do. And these are just pictures from ECSF and the North American meeting in the past, where people have gotten together from across the world to look at this. And the example I'm going to talk about is the global project that looked at the impact of COVID-19 in CF. So this started off when the pandemic started. 8 countries kind of got together, the ones with more well-established registries, to really ask the question, what is COVID-19 doing on the health of CF patients? But over the years, it has grown, and now there were 47 countries in the latest study that was done to look at this. And this collaboration has included countries that have A, not typically been involved in research, and B, don't have well-established registries. Sometimes they're just willing to collect data and share it and be part of the collaboration. And there's been many publications that have come from that work, and these are just a few examples of the publications, but it's been useful to get together and try and answer the question. But there are many other unanswered questions. Rare variants are another one that was mentioned earlier in this symposium. Rare outcomes are another thing that I think is going to require a larger, more global look at trying to understand what's happening with rare outcomes. And I use the example up here of the changing landscape of transplant population after ETI, and that is also a poster and being mentioned in a workshop at the conference. But we know the landscape of CF patients is changing. And the people who are transplanted now after ETI is available are looking like a very different group of individuals. And in one country, it's hard to really look at that because the numbers have decreased so much. In Canada last year, in 2022, there were 7 transplants in the entire country. So it's very hard to do research when you have 7 patients. So I think this is going to take a more global approach to look at what are the outcomes. Because what I'm telling patients as a clinician, someone who might need a transplant, your survival estimate is X, Y, and Z. It actually might not be accurate for the new cohort of individuals that's going towards transplant nowadays. And I think there's also a need to anticipate what the future needs will be of the CF population, and maybe doing that on more of a global scale will yield some important results. So in conclusion, registries, I think, are amazing, valuable resources, and thank goodness for the people who had the foresight back in the 1960s and 70s to generate some of these resources. I think that using data from multiple countries, whether it be registry or you're just collecting information at a different site, it is very doable to harmonize data. It's just a matter of doing it with a thoughtful approach. You just can't sort of put it all together. You have to think about how things are collected and how things are defined. And the CF Global Collaboration, as I mentioned, that's been around for almost 10 years now, is an established group of people who have experience doing this kind of work and would be happy to share, collaborate, connect, advise on research. How do we do this kind of stuff? Or if there's countries that think it's important to compare to other countries, we've done work with other countries in that regard. South Africa, for example, is a good example. There's always opportunities. So if anyone is interested, please feel free to reach out or email me, and I'm happy to answer any questions.
So we have 5 more minutes to answer any questions. If anyone has any questions, 2 microphones here.
We will also have a panel discussion right at the end, so please don't leave after the last talk.
It's all clear.
I do have a question for you. I do have a question for you, since no one else does. So how do you envision a global registry? Is that even possible?
Mm-hmm. Yeah, I actually don't think that that's really realistic to have a global CF registry. That was sort of initially what the discussions were when this group kind of got together in 2013. But I think, as I said, one size doesn't fit all, and people have to have, for the purposes of their country or their group, they have their registry, but then things can come together afterwards and you can harmonize the variables after, but there won't be, I don't think, a global registry.
I'm always an optimist, so I would say not yet.
Well, not yet, but maybe I'm too pessimistic, but no, I think it's just very challenging.
Yes, thank you very much for this presentation. I was intrigued by your data that showed the differences in the reporting between different countries. How do you think that we can solve this problem? Who's going to take the initiative, and how the other countries are going to respond to that? I mean, we all do in our centers whatever we think that is the right thing to do. And it's going to be a little problematic to tell a whole country or a whole world that your way is not the correct way.
Yeah, I think that that's exactly right. And why I don't think that anyone should necessarily tell people how they should collect data, what data they should collect, because that has to come from within the country and the needs of the country, the needs of the community. I think that there are some things that can be standardized, for example, survival calculations, and there is a paper that kind of standardized how those calculations should be done and what should be included in a registry report so that when I read it as an outsider, I can interpret it in the best possible way. So for example, the transplant patients, are they included? Are they not included? How, what's your estimate of missing deaths? All those sorts of things. So from that perspective, I think that there's some guidelines about how to report on certain things. But I don't think it's right for other people to say, you need to collect the best lung function of the year because that's the only way to do it. You have to meet the needs of the community that is collecting that information because it takes a lot of work and a lot of resources.
Thank you.
Lutz Nerlich from Germany. Thank you for your presentation. I think I would like to add a more optimistic end. I think in Europe, I think we achieved, with the European Cystic Fibrosis Patient Registry to cover 55,000 patients. That's larger than the US and Canada. And I think at the end, it's 42 countries in the WHO region. I think there are a few countries missing. So there is a good example of harmonization despite national registries in UK, France, Italy, Germany, at least to have a data set which is comparable and presented as you show it in one slide. Yeah. And I hope that we can expand a little bit, but I think the resources are limited to share everything. But I think at the end, it's a good example of collaboration and harmonization.
Yeah, thanks, Lutz. I agree with you. And, I agree that the European registry is an excellent example of coming together from so many disparate countries with different resources to generate a report that summarizes the European CF community. I think when I said it's not possible, really I was thinking more along the lines of truly a global registry, where initially when we had talked about this, it was about having one sort of platform for all countries to submit data and define certain variables. I think that is maybe not as realistic to do that, but I think that you can certainly have regions that collect information, and those regions can then work with other regions to harmonize their data, for sure. Thank you.
I have the pleasure of introducing Dr. Ahmed Olnar. He's the director of adult CF from Boston Children's Brigham Women's Hospital. And Dr. Mona Kelani, she's an associate professor from the Hashemite University of Zarqa, Jordan.
Thank you. Thank you so much for the invitation for both of us to talk. In true, mentee fashion, as Dr. Gutierrez and the International, Mentorship Training Initiative, we're disciples of his training. And as far as teamwork and QI work and our global, sort of effort using QI methodology to improve care in other places, we're going to do this together. So this is all about teamwork. So Dr. Kalani and I are going to be, sharing the podium today and sharing the work that we're doing together. And we're going to tie in a lot of the discussions that happen. I was wondering, the order of things, but actually kind of works nicely because I think we're going to touch on registry and teamwork and also, mutations and the importance of knowing the people that we're treating. And also I just want to point out here, there's a lot of people involved, and I guess I'm going to get to it, but this was not just a Boston and Harvard collaborative with our Jordanian colleagues, but also involves who I'm going to introduce you to, team members from all over the country and including in the Middle East. So actually, we do have a disclosure, and disclosure is that we received funding from the CF Foundation and the Middle East CF Association, who helped get that grant to do this work. So that is actually something we need to put on this disclosure slide. So I'm going to fix that after this. But it's a pleasure for us to be here together to talk about this. And also, there is a CF Global Health advisory committee, and there's members here, and we've been, discussing, how to best implement, improving care globally. And so, you can't just go in, although sometimes we'll try to do that and try to affect change when there aren't, sort of the scaffolding to allow that to happen. And so I just thought this was important for us to, put out there. And as Hector sort of alluded to as well, we need to have some of the structure in place. And at a country level, things need to be stable geopolitically, and there has to be a healthcare system that recognizes, CF as a health issue at the highest level, so that there can be incentive for improving care to help those institutions that need to also buy into this and provide the resources to the team members that are going to be doing this care, to appropriately train their staff and get everyone ready, make sure that they have pulmonary function testing available and other capabilities like imaging and microbiology. And then the team, and then making sure that there's an interest and there's people that we can work with. And we have incredible team members here from Jordan who we'll talk about. And then also identifying, those patients and families who are always there, and they're actually the first people who reach out and, make that contact often. And so that is an important aspect of it. And to your point, to have a mechanism for being able to collect data. And because without that data, we're not going to be able to tell, how we're going to do things. I always talk about Leroy Matthews, actually, because, we do 14 days of IV antibiotics because that's what Leroy Matthews did. And so, now we're trying to make sure that that's the best way to do things, although back then that was. So with the Stop initiative. So our aim for our project, Jordan and IMTI collaboration, was to build CF care centers in Jordan, and to provide the needs and the care for the people in their communities, and then to engage also with the patient and family organizations. And there's the Jordan CF Charities, and we know Bethena Sub, who is running that organization, to educate and connect with the community and allow us to connect with the community together. And our team members from Jordan already are familiar with this organization, and then to reinforce the need for CF registry in order to be able to see what things that we're doing through QI work to improve lung function, nutrition, and improve just quality of life. I put in the circle already, but this is our team from the U.S., and we have a psychologist, Carolyn Snell, and our nurse, Lena Joseph, and Laura Truix, who is now was a dietitian, now becoming a nurse and almost completing that training, and Eleni, our physical therapist, and along with and the left down there is Chandra Swanson, our new, actually also funded by the CF Foundation in global health work. So she's, we think, one of the first fellows to receive that type of support from CF Foundation to do that work. And then Catherine Keir, who's now our dietitian, and our other members at Fadi Asfour, who is a QI coach here in the U.S., and you guys may know him from different projects he's been involved in our LLCs, because as he says, QI, has changed the way he thinks QI work. And so convincing the people we're working with that doing QI actually does improve care and change was really important. And he is Jordanian, so it's really great that him and Allah Sheikh Shakil, who's a gastroenterologist, she couldn't be here, and Dr. Sama Ouad also couldn't be here, but they're from Arkansas and Columbus, Ohio, also joining with their own resources to make sure that what we're doing is a success. And then Dr. Hussein El-Kindi, who just asked a question earlier, from Oman, but he's part of the Middle East CF Association and also one of our team members. And of course, circling the most important person is our CF community member, an incredible person to be working with, because some of her connections is what has really made an affected change. She knows through social media those patients in Jordan, and we've really gone through sometimes a roller coaster with their health care needs, and and just an incredible asset. We'll talk about her in just a minute. And I'm going to turn it over to Dr. Kalani.
Good afternoon. We are from Jordan, and as Dr. Gutierrez said, but I'm happy to say we're a high potential, low middle income country. We are a multidisciplinary team from Jordan. We present 3 hospitals, Prince Hamza Hospital, Princess Rahma Hospital, and King Abdullah Hospital. I also have other joining institutions in Jordan, like the University of Jordan and the Royal Medical Services, who also participate every now and then. I'm gonna go down. Oh, sorry. This one here.
There you go.
Okay, so we started to work on improving healthcare, CF-related healthcare in Jordan back in 2018 when we decided to establish a committee at the Ministry of Health, and that committee was supported by MECFA, the Middle East Cystic Fibrosis Association, and the Cystic Fibrosis Foundation. This committee at the Ministry of Health had broad representation from all the people who provided care to the cystic fibrosis patients in Jordan, from the university hospitals, military hospitals, and the government hospitals. This committee is still working and has recently been updated and expanded because it's important to have that committee so we can continue to provide services for the patients with CF in Jordan. When we first established this committee, we set goals, and the first goals and demands we had to the Ministry of Health was the establishment of a CF registry because data is important. So together with the USAID, the Ministry of Health got together with the USAID and they started working on the registry. The first step was to establish a steering committee. And the steering committee included people who were in leadership positions, heads of departments, heads of hospitals, people who didn't directly care for patients with CF, but had the executive powers and leadership to help the registry go forward. So they put together terms of reference and they helped establish the registry. From there, we went up to develop a registry data tool. We did have some input from the CF Foundation back then. We had some input from the European CF registry. We did have some input from the Australian registry, but we did custom tailor it for Jordan. So it was shorter, maybe with some different informations we needed that was more specific to Jordan. Then we went out to collect the data. It was a bit different. We did train data collectors, and they went to collect the data from all over the country. So they went to all the hospitals that were known to take care of patients with cystic fibrosis. Basically, they went to every hospital in Jordan. And they reviewed the medical records. Some places still had paper medical records. Others had electronic medical records. For the information they couldn't find in the records, they tried contacting the parents by phone. And then at the end, they did go back to the treating physicians for the missing information. So initially, they had 1,784 patients. And then once they put those patients' names in Excel sheets and looked for duplicates, the number went down to 693. Once they removed the deceased patients, they went down to 500. Once they went over the records and talked to the patients over the phone, the number went down to 385. And those 385, we had a group of pulmonologists and gastroenterologists go over to make sure they fitted the diagnosis of cystic fibrosis. So eventually, CF registry data report was published in November 23. It was a collaboration between different agencies, naming the USAID, the Ministry of Health, the Military Royal Medical Services, Private Hospital Association, and many other organizations. So the distribution of cases, CF cases in Jordan, according to GovernAIDS, the majority of the patients lived in Amman, the capital. Irbid had the second most common cases, and then the rest were distributed in the country. According to the age group, the mean age was 17. A substantial majority was under the age of 30. I mean, that was expected. Our data also showed, there are a lot of gaps in healthcare, in Jordan. So we could document a sweat chloride test in 65% of the patients. The other percentage didn't have any sweat testing documented. Only 15% of the cases had CFTR analysis done, and Delta 508 was the most dominant mutation. So the second goal of the committee was to provide CF medications. So this is what we have now. We have Dornase alpha, that's a Russian medication, when we get it from Russia. We have the enzyme DCAS, we have Tobracel and 7% hypertonic saline. It wasn't easy. We did go through the Middle East Cystic Fibrosis Association. The first batch that the Minister of Health bought, it was bought through direct purchase, with the medications not being registered in Jordan yet. So the MECFA helped negotiate the prices, facilitated the transactions, and guided the distributors. We are currently, some of these medications have been registered, and that makes it easier to reorder them. But we're still working on registering Dornase alpha and the vitamins in Jordan. So just recently, all these medications just became available this summer of 2024. Creon has been available before at the concentration of 10,000 lipase units. We also have, I didn't mention, we have been having and providing dietary supplementations for a while. We have Pediasure that we give out. And Vertex currently is working on registering the ETIs in Jordan.
So, I mean, that slide was so much work and effort by Dr. Kalani and her colleagues. And I was just going to say, Dr. Nasser probably knows this also very well. I think these physicians start becoming adept at being the brokers for these medications, how to get them, and negotiating prices. And it's really, quite a challenge. And I know that Dr. Nasser in Egypt, has a lot of, experience with that. Now, and Karen, as you mentioned, we are not going to spend time talking about access to ETI globally, although that would be obviously something we'd love to talk about and spend a lot of time talking about. And I have had several meetings, and we're, as advocates for Jordan and, and our colleagues in Turkey, this is something that's, we discuss very often and are advocating all the time. And we know that, and this is a slide that J.P. Clancy, I borrowed it from him, and many of us have borrowed it from him, and showing that how there's improvements in care in predicted survival based on these advances that we've seen. And of course, we see that, the slope of the improvement go up since modulators have come in the market. But it's really also important to note, and as we're working with countries where there is an ETI, that through QI methodology, through improving access to medications, which you've now done in this year, getting access to all these medications, there is a lot we can do to improve life expectancy. And so that is, sort of the hope, because there is a lot of anxiety not having access to modulators, and that is something obviously that needs to happen. But, showing this, there is some empowerment in making sure that, we keep to plan. And so our, goal was to also help cultivate and bring these CF centers. Is a slide that my son had made, so I'm really love it. Hopefully you guys like it too. But it's the that there is already CF care happening in Jordan. There is the expertise. We know that the doctors, physicians, the dietitians, the nurses who are here, they are they are all in and wanting to make sure that their patients are getting the best care. But without resources, without, something to cultivate that pot, it is really hard to do. And that's where the QI work and the CF Foundation and our role with IMTI comes in. MECFA, an incredible organization, strong advocates in the Middle East, and not just working like in Turkey and Jordan, but also in Tunisia with, and I'll just put a plug in, Dr. Blankarda and his Turkish team are those mentees that Dr. Nasser trained, who are now training those other countries in North Africa and elsewhere. And this is our plan for Dr. Kalani and Dr. Faisal, Dr. Mohammed, Dr. Iyad, and Hanada to train those other countries around them. And then also the Minister of Health, their involvement is, to cultivate that soil to make sure that, we're seeing a more robust improvement. We did do our benchmarking visit in 2023, and Dr. Kalani will talk about our team, their team now coming here, but we did that last July, and this is just, some various pictures of our trip that included right off the bat actually meeting with the patient and family community, and we had a family education day like on day one. We were able to raise money with our friends in the community, and we brought nebulizers for everybody who came, and we had left over for those who weren't able to come. It was a full packed house all the 8 hours, and nobody left. It was unbelievable. They were all engaged, and it was quite amazing. And so that's where we were initially engaged with the families and the family network. And it was important for us to make that trip because on Zoom, not being able to meet face to face, it's hard to understand the medical system, and so we were able to create this Venn diagram and really split the country into northern and central regions because the south is not as well inhabited, and this a map of Jordan will show you that, and Dr. Kalani showed us that most of the the diagnoses are in Amman and Irbid and less so in other parts of the country, which makes it hard for access. People have to drive many hours, and we recognize that in some of our community members who have to drive to come to us as well. But there's a lot of challenges here. And so I would just say that we are now working with the Minister of Health and those institutions that are government-based. In the northern region, Princess Rahma, and in the central region, Prince Hamza hospitals sort of are the areas where most of the patients are, will be seen. But King Abdullah University Hospital is this incredible academic institution, university. Many of our colleagues here who are in the U.S. and are Jordanian, that's where they receive their medical training, and has a lot of resources, very modern, and so their involvement is critical. Along with, there's the private sector, there's the military institution, very similar to what it's like from where I'm from in Turkey, and sometimes they're just not talking to each other, not really working with each other, yet they're all interdependent often with the things that they need. And as Dr. Gutierrez will say, it's all about making connections and making, friends. And it turned out that the Minister of Health trained in Buffalo in the same hospital. My dad was a doctor. My father was a doctor. And he's a Buffalo Bills fan like I am. And he loves buffalo wings. It was, the conversation was a little bit dry in the beginning. And the next thing we know, we're like, okay. And then is introduced to his son, and now his son is a resident in Columbus, and Dr. Sheikh Khalil, who's in there. So we're connected, and there was a cabinet reshuffling that Dr. Kalani just told me, and he survived that. So he is still the Minister of Health. So I think it's really important to make those connections, though, because now I can text him and say, can we, get help with certain things, and he texts me back, and it's a little bit easier to get a hold of him that way. And I'll say that when we went to go over there, they were recruiting Fadi and Allah to come back, and so we had to scurry them out of the country again. So just with that training and training the team, we also were training these patient and family organizations. Buthena Soub is incredible person who has taken on this challenge of uniting the community together, but this isn't something that she did, before, and that I think that she didn't receive proper, or formal training, like none of us do in many of the things we do. Together with MECFA, and actually MECFA played a huge role bringing her to Turkey, meeting with the family organizations there. There's a mentorship for those communities as well in improving in fundraising, improving in education and advocacy, and something you were telling me that she's already doing, and also getting access. Someone was mentioning, this is a privilege for us to be doing this work, and it's because the learning goes both ways, because there is incredible things we can learn from people working in low resource, areas, and how they are able to make things work and patch things. And it's really incredible. And I think that, it's something that we're learning. And I want to just come back as my last slide before I turn things over to Dr. Kalani, is the connections also continue through our community here. And even though I think the Syrian American Medical Society is in Jordan and so willing to be helpful, it turns out that Noor's father is now the president of the Syrian American Medical Society, and I think they still would have done it anyway, but we, as a great favor, these incredible human beings said, we want to help the mental health support efforts in Jordan. And so with guidance from Carolyn Snell and Noor, who meets with them regularly, and you can see this poster, 544, that Carolyn has put together for us, they have been working on improving access to mental health. And because when we met these families on Education Day, and they were up also speaking to us, and I heard someone else yesterday talking about how they love the Brazilian community, they love the community in Peru. Everybody, we love all these communities because they're just like our communities here. They have the same challenges, same, dreams and same wishes that everyone else has. It was like going to our own family education day. And you're choked up and you're just wanting to make sure you do right by them because they are, struggling while, we're doing so well here. But they contacted 199 family members. They were able to get survey results from 87 of them in households with 112 patients with CF. And they were able to show, no surprise, that there was a lot of depression, anxiety, sleep issues. And these are surveys that parents filled out, not our patients, looking at they're thinking about their children, but also thinking about themselves. And there's also some qualitative data that was done that you'll see more of, but they really felt there was a lack of psychological support. And perhaps it was, like we were thinking, is this something that we want to really delve into? And boy, just like our community here, mental health, was the number one thing. That's the support that they were looking for and need help with dealing with mental health, need education on how to speak to their children, because they had trouble doing that. There was a, young lady who was up, tearful on the stage saying that I'm sorry that I've ruined my parents' lives because they have to take care of me. It was like gut wrenching. And of course her parents did not feel that way. And then also the managing of a stigma in the CF community. So now we're introducing other validated scales for them to use. And so we're working together to actually, our Jordan community is here this week with us, and we're going to they're going to be presenting to us some of this data. So I would love for you to to come and look at that poster. And so, sorry, there was one more slide. But what we're doing right now, we're meeting twice a month. We're doing, and this has been going on this whole year, and it's going to be continuing with a larger team. We're doing doing QI methodology teaching and implementation. We're doing fishbones, we're doing process mapping, and trying to, look at all the barriers and trying to make a difference. And our partner, Dr. Fadi Asfour, did go to Jordan and was able to spend some of his vacation seeing family actually working there and going to the different hospitals and, doing some hands-on training there as well. So that's really incredible. And our ultimate goal with this, education and curriculum establishment is to, create CF guidelines that are specific to Jordan's needs and Jordan's resources.
So where we are right now, right now in Jordan, we have diagnostics available. We have sweat chloride measuring kits that measure the chloride levels. We didn't have those before, and we have a plan to do CFTR mutation analysis for all our patients. That's going on. Hopefully, the beginning of next year. I think that we will start collecting the samples. We do have the therapeutics available, the DNAs, the vitamins, the enzymes, hypertonic saline. We have mental support available. Right now, the Jordanian and U.S. teams we're here in Boston. We did have the visit from Dr. Fadi back in April. It was in April, yeah. And now we're here, and we have a workshop after this conference at Boston at the Children's Hospital. And yeah, a larger group of us will meet again in Istanbul next year to visit Marmara University. And so we have more of our team members to get exposed to other centers. Yep, and this is where we are. So these are some pictures of our patients in Jordan. And, you know, there's the same CF patients as everywhere. You know. Just to finish up with some of the pictures.
These are like really incredible people. I know you shared a lot of stories about these folks, and they all just seem like larger than life and, you know, incredible, you know, young people who are.
Marah, she's 15 and she's doing well. She's doing okay, but she's very enthusiastic and outgoing and loves everybody and really great. Rana, not as, I mean, she has really bad lung disease, but yeah.
I was going to say, and also, though, we want to thank our larger community helping us. So we have our U.S. teams here in Boston and Utah, Ohio State, and Arkansas. But the Jordan-based team, I think, is a critical piece. This is a lot of people who can come. I don't know if you want to just say a few words about them.
Yes, we have Dr. Faisal Qtesh here from the University of Science and Technology. We have Dr. Muhammad Al-Wahshi from Princess Rahma, Dr. Iyad Al-Tamimi from the University of Science and Technology, and Hanada, who's a nurse from Princess Rahma Hospital. They're with us here today, and in addition to the other team members who couldn't come, but hopefully will be able to come on later dates.
Thank you.
Thank you.
We would like to invite all the speakers, and also we have a patient here, a patient family partner, Noor. We would like to invite all of them here, and if you have questions, please, we would like to have a panel discussion. And I will start to open up kind of a little bit, break the ice. Noor, you shared with me a little bit about your story. Would you like to share with everyone, just whatever you feel comfortable?
Thank you for inviting me to be up on this panel. It's an honor to be able to help in any way possible. I am privileged because I was born and raised here in the United States, but my family is back from Syria. And I was sharing a story about just one of my cousins who lives back in Syria. And I stay in very close touch with her. And I was just sharing, you know, it's the life here and there is like night and day. They only have a quick, just to put things into perspective, just they get maybe an hour and a half in total of electricity in a 24-hour period. So there are times she'll be messaging me at a very odd hour, and I would ask her, "Oh, Ella, why are you awake?" And she'll say, "Well, the electricity just came. I have to do my nebulizer treatments and get in whatever I can of her vest therapy so that she can continue to fight the battle with CF that she has every day." So I'll leave it at that, and then if we have any questions, I'm more than happy to answer.
From your original country, which I assume also have limited resource like ours, what would you as a patient would have hoped the doctors or the medical system have helped you or your families who had the same problem? Because I'm sure you feel the impacts of difference of the medical care from where you come from and how you are being treated here. Like how I feel when I was back home and just day 2 of conference. So what would you have as a patient would I hope the doctors back home could have made a difference?
Did you understand? My number one piece of advice is that's helped me the most is to be able to work with my doctors together as a team. and for me to listen to them, but also for them to listen to me, and for us to work together to create the best healthcare or the best plan of care for wherever my health may be. And I think really just listening goes a very long way. It sounds very simple, but believe me, it's not.
Yeah, so I will add to that a little bit. So in other countries, there is still a paternalistic approach to care, where it's very like the doctor says something like, correct me if I'm wrong, but I was born in Romania, so at least there, that's how it is. The doctor tells you what to do, and there is no questioning the doctor. If you don't like it, you go to someone else. So basically, like, there is no co-production of care. This is something that we are very fortunate to have here, and it's a very different approach compared to other countries' cultures.
Hello. I'm much louder. My name's Davina. I'm a mother of a child with cystic fibrosis. Here in America, obviously, we have access to every medication under the sun, essentially. As a advocate for patients in America, and then with a strong care for those across the globe. For those of us in America, how can we best support the work that's being done in the Middle East, and then specifically Jordan, since you spoke on Jordan? How can we support you best and be an advocate here for the patients fighting the same disease our children are fighting across the world?
Well, I think the patients in Jordan will be very appreciative just knowing that, you know, that you think about them, and that, you know, that you might be willing to share, you know, your expertise or what you do to make your child feel better. They would be just very appreciative to know. Other than that, I mean, we are working together to use the resources we have in Jordan to better their children. You know, to use everything we can, like knowledge from here, in addition to resources, medications, like everything we can. We're also trying to work on better care models where we have, you know, the multidisciplinary teams. That's something new in our area, where, you know, like people can discuss their plan, the management plan, and make changes. But I think they will just be grateful to know that, you know, you think about them, you care about them.
Yeah, I was just going to add that, I mean, we know, and so first of all, we are connected by WhatsApp, as Dr. Gutierrez said, that WhatsApp is somehow, like, that's the way we communicate. And we just went through a terrible loss in the Jordan community. One of our connections there, I mean, he just recently passed away. And so one of the messages that we have to, like, the work that we're doing and to advocating for, you know, more medications is that, you know, we don't have, you know, the luxury of time. We want to make sure that we are able, you know, we can make a difference now, and really there is some great urgency. So, you know, just trying to help, you know, helping the CF Foundation to help the work that they're doing to help us go and do these things in Jordan and other places. I think that that's maybe where the support can go as well. Yeah, I don't know if you had anything else to add to that.
Yeah, I would like to add something. I'm very impressed and so fortunate to see the work that Jordan has done, and not just at the center level, but at the country level. That is something that actually needs to be celebrated. The other part is, I think by mentioning what you are doing, what we are doing, it's attracting other stakeholders. I realize that we, as a medical, my hat is not to work with the families. Somebody else can work with the families, teach the families in other countries to operate better, more efficiently. And we were fortunate. Cam McLeod is actually helping us to nurture, to guide, to provide some guidance to families in one province in Argentina, Mendoza, to do things that she tried many years ago. So that kind of expertise, I mean, they have Messi now in Argentina for families trying to learn how to do things. So my point is, by not advertising it, but allowing other people to understand what the challenges are and what we are able to do, actually brings another idea as an expert to the table. And that's one thing that is very fortunate to see.
I'm just going to add, and like the funding to bring people here, I mean, it's a great, cost, but it's really important. So because Dr. Kalani wants to talk to Dr. Ann Stevenson about how do we harmonize the Jordan registry with the work in the European CF Congress. So hopefully these, this work will lead to connections and communication like that. Yeah, go ahead. Oh, sorry.
Hi, I just wanted to say, this is more a comment than a question, but as somebody who has worked with Nora since she was very young, this is an amazing thing to see you up there.
Oh.
And I cannot think of anybody who's more exquisitely qualified to do this work than you, Nora. So you've always given back to the CF community, even at your sickest. So it's just, I just felt like I wanted to congratulate you and just say how happy I am to see you so well and see you sitting there. So that's it.
Thank you, Julie.
I mean, we are working on that. I mean, we are working on, creating our own funding. Like that's something we're working on with the Families of Cystic Fibrosis charity. We want to be able to fundraise, maybe approach pharmaceutical corporations in Jordan to be able to get the funding to fund the educational activities, the medications that we could provide every now and then, the nebulizers, the respiratory equipment. But right now we are still getting funding from the CF Foundation, MECFA through the CF Foundation. But I mean, we are appreciative, but we also want to be able to raise our own funding. We're working on that.
I was just going to ask Karen, the importance of also understanding, who's out there and what their mutations are is really also critical. So, I have no idea how to answer your question because it's it seems overwhelming, but funding for the efforts to better understand, supporting CFTR2, the work of trying to analyze, the mutations to know, what therapeutic approaches we might, have for such patients. But
yeah, I'll piggyback onto that and say, I know you mentioned that you have a plan or some sort of funding or a plan to do genotyping for more patients in Jordan. So that's really wonderful. I will say that one of the questions that CFTR2 is asked somewhat frequently is, can you help us genotype our patients? So there are, some number of countries that have access to maybe a small or even a large variant panel, but it's not going to hit everybody in that country. And so there definitely are opportunities, again, I don't know what kind of funding you have, but there would certainly be opportunities for people that are looking just for help in genotyping so that we can define a little bit better what's going on in that population and then use that for, others in similar regions of the world or things like that. So I think there's certainly opportunities there as well as many, many others, but I'll mention that one specifically.
Yeah, I'm not going to tell you. One thing that is clear, though, is the return on investment is a very good business decision. The funding that we have received from the foundation has been multiplied many, many times. So the cost might be 100, and you multiply that 10 times. And that translates into longer survival, better life quality for the patient. And that in itself is what we get paid. By the way, my team texted me, benchmarking funding is essential too. I think we have learned, and I think Ahmed might share too, just visiting what they are doing is an eye-opener experience. It's a very intense time, but you get a lot to work for many months after that. Yeah. So the benchmarking for us has been a hallmark of doing this. The travel expenses from one side of the world to 8 time zones or whatever it is, yeah, complicated. If you go closer, let's say the U.S. with Mexico should be a no-brainer. And that is helpful.
I just sent a message about Piper's Angels to our CF community, so I have your contact on the, I'm going to utilize that.
We will take 3 more questions, so we have 3 more people. And the rest of them, please send them online.
My name is Fadi S04. I'm from Jordan, and I'm a pediatric pulmonologist practicing in the US. I've been very involved with this work, and I would happily like to answer the question with what we can do with more funding. I think starting a newborn screen in Jordan would be great, and that takes a lot of money, especially in the beginning, to just like study and see the true incidence of cystic fibrosis, to understand the mutations. But I also think we can buy VIS machines. Like, we do not have VIS machines in hospitals. So when children are in the hospital for an exacerbation, they're not able to use a VIS machine. We can buy a bunch of VIS machines, have them in the hospitals. We can buy more machines and deploy to families that have multiple kids with cystic fibrosis or the ones who are sicker. But also investing in the teams who are in Jordan, bringing them to the conference. Doesn't have to be the American conference, could be the European, could be any regional conference. But I think the teams are very passionate, they're willing, they are interested, but I think they need opportunities, they need to be exposed to other centers, other countries, what work is being done locally, regionally, and internationally. So I think if you have the funding, we will work with you, we will not say no, we will use it. Thank you.
I would just, one thing, and Fadi, one thing that you didn't mention that's your wish is that newborn screening. I mean, that will sort of also help us define, I mean, these countries don't do newborn screening. We're also working in Kenya, and we just don't know who's there who has CF. And newborn screening would be something, like in Jordan, that costs $200,000 a year. Like, that is an investment that could really help define things. So thanks, Fadi.
Yeah.
Hello, hi. My name's Gail. I'm a CF mum from England. My daughter has the luxury of having access to Vertex modulators. Obviously, that's transformed her life. Just in response to your statement that you just hope that other countries are listening, and for people in Jordan and everywhere else, I want to reassure you that we are. There are a lot of us that really, really care about access for people without these drugs. Tomorrow we're going to be taking a petition to Vertex with 140,000 signatures, and we're going to deliver it to them and say that patients in Jordan and other countries do not have time to wait. They need to lower their prices in poorer countries and let everybody have access. So if anybody's free tomorrow at 10 o'clock, we're meeting out the front, we're going to walk down, deliver the petition and come back. And we're doing it for you. We've actually got a picture of a couple of children from Jordan, as well as pictures of children from other countries. And we'd love you to join us if you can. So thank you.
I'm Dr. Natalia Kashirskaya and from Russia. And but my advice, because I'm in the group with CF Global, I'm also, so I represent as doctors and international, and also as CF Association, because I also am at the head of the Parenteral Association. And we already did this sort of twinning between countries that already have a lot of resources and the countries which do not have such resources. But so my advice is that here in the United States, you use more this twinning program, like it is now between Jordan and Boston, and like in Lutz represented, that we have in the European Cystic Fibrosis Society really this twinning program. And you can look how it works. I think that this should be organized on the regular basis here. This will help a lot of the other countries. And also, I think that this is very important, what is from my experience, and that's what Hector also mentioned, that many doctors, like also patients, they do not speak English language. So my advice is that, like what we did, translate to Portuguese, to Spanish, to, Arabic language guidelines, and renew them. Then you will be able immediately give it to your Ministry of Health or somewhere else, and even people that are not medical, they can use this, but don't keep it in English. Keep it on your own language. This is a very important thing.
Okay. Yes.
My name is Therese Boshra. I am pediatric pulmonologist from Egypt, Cairo, Egypt, and I have an obligation to thank MECFA, CF Foundation, and my magician, Professor Dr. Samia Naz, and she worked like that exactly in Egypt, and she did of nothing to achieve something. Who cares about CF patients, from diagnosis to therapy, and we hope to reach, as my colleague said, to reach Trikafta safely, inshallah, as to complete twinning of the program and to have the opportunities that CF patients have the hope everywhere. Thanks again, thanks for you, Dr. Samia Naz, and we hope to continue together as a twinning program. Thank you.
Samia Naz.